Welcome to the Deep Dive. Today we're tackling a really important topic for anyone doing adult spinal deformity surgery. Proximal Junctional Kyphosis, PJK. It's that complication we sometimes see cropping up just above our fusion constructs.
It really is, and it can significantly impact our patients. So today, we've gathered quite a bit of research looking at everything from the biomechanics, the forces involved, to practical prevention and management strategies.
Good. The idea is to really distill what we know right now about PJK.
Exactly. Give you a solid, concise update on the risks, the mechanics, and what we can actually do about it.
Okay, let's jump right in. How are we defining PJK clinically? What's the standard definition we should be using?
Right, so the most widely accepted one comes from Sardar and colleagues in their 2021 review in spine deformity. They define it radiographically. You're looking for a proximal junctional sagittal angle. That's the angle between the UIV, the upper instrumented vertebra, and UIV plus 2, so 2 levels above it of at least 10 degrees.
Okay, 10 degrees.
And this is the important part. It also has to be at least 10 degrees greater than what the patient's measurement was before surgery.
So it's not just the number, it's the change that really matters.
Precisely. That change is critical.
And how often are we actually seeing this show up on x-rays after surgery?
Well, it's surprisingly common, unfortunately. That same review by Sardar et al. Looked at the literature and found the reported incidence of radiographic PJK varies quite a bit, but it's somewhere between 17% and, well, up to 46%.
Wow, it's almost half in some series.
Hmm.
But just seeing it on an x-ray doesn't always mean it's a clinical disaster, right? That's where PJF comes in.
Exactly. That's a crucial distinction. There's radiographic PJK, and then there's proximal junctional failure, or PJF. Folks like Nguyen et al. In current reviews in musculoskeletal medicine back in 2016, and Hyun et al. In the Korean Journal of Spine in 2017 really clarified this.
So PJF is the worst version.
Yes, PJF is the more severe end of the spectrum. It's when things have really gone wrong, maybe a vertebral fracture at the junction, subluxation, the implants might fail, or the patient develops neurological issues. It often means heading back to the OR for revision surgery.
Okay, so PJK is the sign, PJF is the failure requiring action. What does PJF actually mean for the patient's day-to-day life?
It can be devastating. Kim and Iyer reviewed this in JOS in 2016. PJK itself can range from totally asymptomatic to causing significant pain or functional problems. But Lee and Park, in their 2016 Asian Spine Journal review, really zeroed in on PJF.
And what did they find?
They found PJF has really significant negative impacts, more pain, neurological deficits, serious difficulty walking, and it can even lead to social isolation. It's a major setback after they've already gone through a big operation.
Definitely something we want to avoid. Does it tend to happen quickly after the initial surgery?
Often, yes. The timing is interesting. Lee and Park also noted that about 2/3 of PJF cases, maybe 66%, happen within just the first 3 months.
3 months, wow.
Yeah, and around 80% occur within the first year and a half. That early onset really tells us we need to be thinking about prevention right from the start, understanding the biomechanics.
Okay, let's pivot to those biomechanics then. What makes that junction vulnerable?
Well, a lot of work has focused on sagittal balance and stability. There was a biomechanical modeling study back in 2012 by Camerata and colleagues, published in Studies in Health Technology and Informatics. They found a link between PJK and overall sagittal imbalance, but also reduced stability right above the fusion.
How so?
Their model suggested that disrupting the posterior ligaments and maybe some degeneration in the facet joint capsules during the surgery itself can weaken that proximal junction. So our own surgical approach might inadvertently set the stage.
That makes sense. We fix the main problem but create a new stress point.
Kind of, yeah. And clinically, a retrospective cohort study by Mendoza-Lattes and team in the Iowa Orthopedic Journal in 2011 supported this. They found PJK was more common when the thoracic kyphosis after surgery remained, significantly larger than the corrected lumbar lordosis.
So the shape of the remaining spine matters.
Absolutely. And also, if achieving overall sagittal balance meant the patient had to really tilt their pelvis backward, that pelvic retroversion to compensate, that also increased the PJK risk. The analysis pointed to the size of the thoracic curve and overall sagittal balance as key predictors.
So it's not just about getting the SVA right, but how you get there. The regional alignment counts.
That seems to be the case. A more harmonious curve distribution looks better than relying heavily on pelvic compensation.
Okay. What about the hardware itself? Our instrumentation choices?
Right, that's another big area. Camerata's group published another biomechanical study, this time in spine, in 2014. They used simulations, which is neat because you can isolate variables.
What did their simulations show?
Well, they looked at things like facectomies and cutting posterior ligaments at the UIV and UIV plus 1, doing bilateral complete facectomies or resecting those ligaments increased the biomechanical stresses associated with PJK. Using pedicle screws right at the UIV also increased those stresses.
Which intuitively makes sense. More disruption, more rigidity, more stress next door.
Exactly. But interestingly, they also looked at alternatives,
Like what?
like using proximal transverse process hooks at the UIV instead of screws. Their simulation suggested that using hooks reduced those stress indices by about 26%.
Interesting. So a less rigid anchor point might be beneficial.
It seems plausible, yeah. Allows for a bit more physiological transition. They also modeled transition rods, or rods that taper to a smaller diameter at the top,
Did those help?
modestly. Going from, say, a 5.5 millimeter to a 4 millimeter rod proximally showed a small decrease in the PJK angle and the flexion forces. On the flip side, increasing the bend, the sagittal curvature in the rod itself actually increased the PJK angle and forces.
So a very sharp bend at the top isn't great biomechanically.
Seems not. Their takeaway was basically try to preserve the posterior elements up top, consider transition rods or hooks, and avoid putting too much kyphotic bend in the rod right at the junction. These things seem to lower the biomechanical risk.
Very practical points there. Now, what about the patient? Things like bone quality.
Ah, yes, osteoporosis. We know it's a risk factor generally, and a 2023 biomechanical study by Zhao and colleagues in clinical biomechanics looked specifically at PJK using finite element models.
And
They found that as the simulated bone got weaker, the stresses inside the vertebrae just above the fusion, like T7 and T8, went up significantly during movement. Makes sense. Weaker bone doesn't handle the load as well.
so the bone itself is more likely to deform or fracture under stress.
Precisely. They also saw higher stresses on the discs above the fusion in the osteoporotic models, especially in bending. And no surprise, the stress on the pedicle screws also increased in weaker bone, higher risk of loosening or pullout.
Okay, so osteoporosis clearly makes the junction more vulnerable mechanically.
Definitely. It increases stress on bone, discs, and screws. So identifying and treating osteoporosis seems really key.
Are there other biomechanical factors linked to the overall spine?
Yes, definitely. The overall alignment and the forces across the construct are huge. A study by Alave et al., coming out soon in the Global Spine Journal, looked retrospectively at patients with long fusions to the pelvis.
And what did they find?
Patients who developed PJK tended to have worse global malalignment before surgery. They actually developed a model defining a high-risk zone based on shear and compression forces at the junction. This is pretty accurate, like 86% in predicting PJK.
So global alignment is a big driver.
It appears so. They specifically flagged postoperative shear forces at UIV plus 1 as an important risk factor. Minimizing that shear seems crucial.
And does the length of the fusion matter? Like fusing down to the pelvis?
Yeah, another study, this one a computational study by Nguyen et al. In the Journal of Biomechanics in 2024 looked at T10 to pelvis fusions. Their models showed that this long fusion increased shear forces and actually decreased compression at T9, the vertebra right above. And this happened regardless of segment mobility changes.
So the long lever arm itself changes the forces up top.
That seems to be the implication. So, putting it all together, the biomechanics are complex. It's about sagittal balance, stability, surgical disruption, instrumentation choices, bone quality, overall alignment, and the forces generated.
Okay, that's a great summary of the forces at play. Now, the crucial part, how do we try and prevent this from happening?
Well, given how many factors are involved, prevention really is key. As Aurora and colleagues highlighted in a 2023 review in Neurosurgery Clinics of North America, we need a proactive strategy.
Makes sense.
Shotline et al. In a 2025 review in Orthopedics and Traumatology, Surgery and Research, put it bluntly, the best treatment is prevention. That means careful risk analysis and tailoring the surgery. And Serpa et al. In the European Spine Journal in 2020 stressed just optimizing the patient's overall health beforehand that's fundamental.
Right. Start with an optimized patient. What about specific surgical techniques during the operation?
There are several ideas floating around. Safia Alal wrote a technical note in Operative Neurosurgery in 2017 describing things like prophylactic vertebroplasty, cementing the vertebrae just above the fusion. Also, using those transverse process hooks we mentioned, specific ways to contour the top end of the rod, and even ligament augmentation. They found these were feasible and didn't add much time for high-risk patients.
What about screw technique?
Yeah, an interesting prospective study by Yannick et al. In the Journal of Spinal Disorders and Techniques in 2015 looked at Scheuermann's kyphosis. They tried a modified screw insertion at the UIV, leaving like two threads exposed.
Just backed out slightly.
Exactly, and they found significantly lower PJK angles and actually no PJK compared to standard insertion in their cohort. A subtle change, potentially impactful.
Interesting. Any other hardware or soft tissue techniques?
Let's see. Daniels et al. Proposed an interlaminar fixation construct at UIV in orthopedic reviews in 2019, suggesting it might lessen PJK severity with minimal added trauma. Zalul et al. Described using Merceline tape as a sort of check rein strap proximally in orthopedics in 2016. Early data looked promising.
Like a soft tether.
Kind of, yeah. And biomechanically, Zhao et al., again, in Clinical Biomechanics 2021, suggested augmenting two segments proximally with cement might be better than just one. Another Zhao study, this one focused on ligament tethers, suggested that using tethers across 3 levels could create a more gradual stress transition.
So lots of ideas around reinforcing or creating a softer landing at the junction.
That's a theme. Aubin et al. In Spine Deformity 2015 found biomechanically that extending instrumentation might lower risk, but also preserving local elements and using more flexible anchorage helps. Frade et al. In 2018, also in Spine Deformity, biomechanically supported using hooks and limiting dissection proximally.
What about semi-rigid options?
Yes, that's being looked at too. Viswanathan et al. Did a cadaver study on semi-rigid fixation reported in Journal of Neurosurgery, Spine, in 2019, and more recently, Kadyu et al. In Global Spine Journal 2025 did a cadaver study suggesting an APS system plus hooks had favorable biomechanics compared to other semi-rigid options for PJK prevention.
Okay, so less rigid fixation, potentially hooks, maybe semi-rigid systems, augmenting bone or soft tissues. Lots of technical strategies. What about the alignment goals we talked about earlier?
Crucial for prevention. Schlobin et al.'s 2022 systematic review in World Neurosurgery really hammered home the need to avoid both overcorrection and undercorrection of sagittal alignment. You need to hit that sweet spot.
And how do we define that sweet spot?
Well, Sakuma et al. Published a case control study in Spine Surgery and Related Research in 2021. They found that a low postoperative PI-LL mismatch, specifically PI minus LL being 0 or less, was a risk factor. This suggests you want the postoperative lumbar lordosis appropriately matched to the pelvic incidence, maybe even slightly more lordosis than PI.
Got it. So alignment targets are key.
Absolutely. Balmestino-Chris et al. Reviewed this in the International Journal of Spine Surgery in 2023, really emphasizing these alignment-focused prevention strategies.
And don't forget osteoporosis.
Right. We touched on it biomechanically. Chatelain's 2025 review explicitly states treating osteoporosis helps prevent PJK. And Echt et al.'s 2021 systematic review in Global Spine Journal found the strongest evidence for prevention in osteoporotic patients was actually using perioperative teriparatide.
Okay, so medical management of bone health is a big piece of the puzzle.
A very big piece. Other things mentioned in the literature include hybrid instrumentation, mixing screws and hooks, as Yun et al. Noted in their 2017 review. The optimal UIV level is still debated. Solomon's 2023 review found inconsistent data on whether lower thoracic UIVs are riskier. Malapela suggested maybe using the sagittal stable vertebra in certain pediatric cases. And Hean also mentioned prophylactic rib fixation in some scenarios.
It's clear there's no single magic bullet for prevention. It's about assessing risk and layering strategies, patient optimization, careful technique, achieving good alignment, and managing bone health.
That's a perfect summary. It's a multi-pronged attack.
Okay, but what if, despite our best efforts, PJK does develop and becomes problematic? How do we manage established PJK or PJF?
First thing, as Chatelain et al. Pointed out, not every radiographic PJK needs surgery. If the patient is doing okay, sometimes monitoring closely and using non-op treatments like PT or pain management is enough.
Right. But when do you need to operate?
The main triggers for revision surgery are usually worsening pain that non-op measures can't control, new or worsening neurological problems, or clear signs of instability on imaging like an unstable fracture, significant slippage, spondylolisthesis, or cord compression at that level.
And what does the revision surgery typically look like?
Generally, according to Chatelain, it involves extending the fusion proximally to get to more stable ground. And usually you'll combine that with decompressing any nerve impingement that's contributing to the symptoms.
Stabilize higher up and free up the nerves.
Pretty much. McClendon and colleagues actually have a great video article in Neurosurgical Focus. Video from 2020 showing some techniques. They emphasize tailoring the approach. and their group published a retrospective study back in 2012 in Spine on correcting upper thoracic PJK using osteotomies and traction, showing good angle correction without neurological issues.
So complex revisions might need osteotomies too.
Definitely. Cecchinato et al. Stressed in the European Spine Journal in 2015 how careful preoperative planning is for these revisions, especially selecting the right osteotomy to restore alignment. And just as a cautionary tale, Ikegami et al. Had a case report in Spine in 2015 of PJF happening at an ankylosed junction above a long fusion, led to bad instability and neuro problems.
Wow, so you even have to consider underlying conditions like AS when choosing fusion levels.
Absolutely. It adds another layer of complexity.
This leads to a final point. How should we even be thinking about clinically relevant PJK? Is there a magic number?
That's a really interesting discussion right now. Hills and Kelly argued in the International Journal of Spine Surgery in 2023 that PJK is really a spectrum. Just trying to draw a line and say relevant versus irrelevant based on an angle might be too simplistic, leads to misclassification.
So what's the alternative?
They propose thinking more probabilistically, using models perhaps, to give patients a better idea of their individual risk of progressing to actual failure, PJF, over time, more of a precision medicine approach. And maybe just use the term asymptomatic PJK if there are new symptoms, rather than trying to set some arbitrary threshold for symptomatic.
Focus more on the patient and their trajectory than just the X-ray number. I like that.
Me too. So wrapping up our deep dive today, PJK is clearly a major challenge. We've seen it's driven by complex biomechanics involving alignment, stability, instrumentation, and bone quality. Prevention relies on a combination of patient optimization, meticulous surgical technique, hitting alignment goals, and managing bone health. And management, when needed, often involves revision surgery to extend the fusion and decompress nerves, but requires really careful planning.
That covers a huge amount of ground. It really underscores the complexity we face. Which brings us to a final thought for you, our listeners. Given this multifactorial nature of PJK, everything from the patient's biology to our surgical choices, where do you think the most promising avenue for future research lies? Is it better predictive modeling? Novel instrumentation? Improved biologics for bone health? Definitely something to ponder for your next complex spine case. Thanks for joining us for this deep dive.